We'll continue on now with Dr. Abikhzer, who is a nuclear medicine specialist in Montreal working at the Jewish General Hospital. He obtained his medical degree at McGill, followed by the fellowship training, and then went on to Haifa, Israel to do a 2-year fellowship dealing with novel SPECT CT and PET CT hybrid cameras, as well as novel radio tracers. And he's published multiple articles, interests in whole body SPECT scanning, as well as an interest in infectious imaging with PET CT. And as you notice on his discussion today, we're going to be looking at cardiovascular infections using PET CT. And the podium is yours, sir.
Thank you very much. For me, it was a short distance to get here, so that was practical. But thank you very much for the organizing committee for inviting me. So when we talk about PET for cardiac imaging, the previous speaker spoke about myocardial perfusion imaging, but then there's a whole large field of other PET applications for cardiac imaging. One being inflammation, sarcoidosis, which is routinely established now. I'm not going to be talking about that. I'll be focusing on the next large application, very rapidly growing, and I very much encourage you guys, and I'm going to hope to convince you guys to start doing this, is imaging cardiovascular infections with FDG PET. So we're going to briefly talk about FDG for infection principles, the protocols that we have to use for imaging cardiac infections, and different types of cardiovascular infections. So an ideal infection radio tracer doesn't exist, but ideally what we would like is a radio tracer which is very sensitive, which could differentiate between inflammation and infection. Acute and chronic infection is maybe even pathogen specific, has a very rapid clearance, gives excellent image quality. It doesn't have much radiation. We can image rapidly. So, you know, this is something that many researchers have been trying to develop for many years, but there's nothing really that's practical, available, usable right now. What is available and what is practical and what is widely available anywhere you are in the world right now is FDG. So in terms of infection radio tracers, there are a variety of ones that are commonly used: white blood cells, FDG, gallium-67. Who here uses mainly white blood cells for infection imaging? Show of hands. Who uses gallium? Who uses FDG? Mainly the Quebec people. So I'm going to try to convince the rest of Canada that it's time to move on to FDG for infection imaging. There are many advantages compared to the SPECT tracers. First of all, you're imaging on a PET camera. You can't compete between a SPECT and a PET camera. It's just, no matter how good your radio tracer is, just your sensitivity resolution is uncomparable. Secondly, FDG, I don't know, depending on where you work, it's very variable, but the cost of FDG is probably less than the cost of white blood cells, especially if you don't have, it's definitely less than the cost of white blood cells unless you have in-house labeling. And with the decreased availability of gallium, as there's only one more manufacturer still producing it, and I'm sure in the next few years, maybe they will even stop, gallium-67 won't even be available in probably 5 to 10 years. So we have to move to the PET world, where FDG right now is what's the most available. It has excellent image resolution. It's a quick study. You don't need to do any cell labeling. If you have a PET camera, and you definitely have FDG, so it could be available. And how does it work for infection? Basically, when there's tissue injury, there's a lot of acute inflammation that's happening. There's upregulation of the GLUT receptors, GLUT1, GLUT3. Macrophages are increased. So there's a lot of increased cellularity, and therefore the FDG is going to go up, is going into the cells, and we're going to be able to image the increased uptake in these infectious or inflammatory cells. So we always have, as it's on a PET CT, you always have a CT with it, which is a major advantage. Unless I would hope that nowadays most people are doing SPECT CT, but with PET you have no choice, and you can do a PET CT. It's a very quick imaging study. The patient doesn't have to wait 24, 48 hours for imaging. Imagine the hospitalization costs of waiting for a gallium or a white blood cell cost 24, 48 hours later, compared to the cost of FDG. Just in that, the loss of time and the faster patient management, more appropriate, that itself is cost effective. There's a lower radiation dose than the other infection radio tracers. And I spoke about the cost that I believe, and everybody's going to check in their own centers, but it should cost less than even the SPECT radio tracers. The disadvantage is that you need to have a PET scanner in your center. And it does also, it's a tracer we use for also infection, imaging of malignancy and inflammation. So it's not entirely infection specific, but with the patterns that we see and with the CT findings, most of the time we're able to tell the difference as well as the clinical history. What we need to be able to do is that we need to be able to respond very quickly. These are urgent indications. So it's probably even more urgent than staging of a breast cancer. An infection is something that you have that you need to diagnose right away, treat right away. Within 5 to 10 days, either you missed out on the opportunity to accurately image the infection because the antibiotics had its effect, or the patient died from the infection or was cured. So this is something that our emergency applications, we need to be flexible, we need to be rapid, we need to have same day, next day appointments, keep emergency slot open for these indications. So when we're imaging cardiac infections, we need to have good cardiac preparation. We need to suppress the myocardium. We know that FDG uptake in the myocardium is usually very intense and high. So we need to prepare the patient in order to reduce that and to remove the physiological uptake in order to better see the paracardiac valvular structures and adjacent structures. So what we do is we have a protocol, and we make sure that the patients, and especially the inpatients, the nurses, everybody has to know about it because they're injecting glucose for a variety of reasons. So it's not only just following the diet, but everybody needs to be on board and follow the protocols and strictly. So there are 3 major factors that are used to suppress physiological myocardial activity with FDG. The prolonged fast, anywhere from 12 to 18 hours, the longer the better. The use of a low carbohydrate diet for the day, for the 2 meals prior to the fast, at least. So you can mainly fat, no carbohydrate diet. And in some centers, or is routinely used, or in other centers, it's occasionally used, heparin as an injection prior to the FDG injection. Inpatients are particularly problematic just because there's so much going on, so much medication being injected. They're on dextrose strips. It's very, very important to work with the nursing staff and to make sure that the proper protocols are placed together with the dietitians for the food in the hospital, because the success rates for the inpatients will be generally lower than the outpatients, who tend to follow the instructions much better. So the first application we'll be talking about is infective endocarditis. Infective endocarditis is associated with very high mortality. And it's been shown that the faster the surgery, especially within 2 days, there's better outcomes. And that's why it's very important to image these patients with PET as soon as possible. We can't delay appropriate treatment. Especially in the setting of prosthetic valves, the mortality increases a lot. So the standard so far has been to diagnosis through a combination of clinical, microbiological, and echographic criteria, mainly through the modified Duke's criteria, which, however, has been shown to be limited. The first step is usually a transthoracic echocardiogram, which has relatively low sensitivity, but is the easiest and fastest and most appropriate first step. Then in selected patients to proceed to TEE, which is much more sensitive, but sometimes may require follow-up, and especially in the setting of prosthetic valves is often a challenge. So the use of PET scan has been increasingly being implemented in the guidelines and in other review articles. in the flow chart of the workup of these patients. Patients with suspected endocarditis often proceed with echocardiogram, and depending on the clinical scenario, go to TE, to surgery, to cardiac CT. But especially in this, but we're going to be talking about all the different indications in ventricular carditis. But those who have possible IE by Duke's criteria, the use of PET will help resolve the question of is there endocarditis or not, much quicker than doing a follow-up echocardiogram at 7 to 14 days. So in the setting of prostatic valve endocarditis, this is now relatively standard that the use of PET scans increases the sensitivity of Duke's criteria much, much higher, from 50 to 88%, reclassifies the patients to the correct Duke scores, and in a meta-analysis, the sensitivity of FDG PET for prostatic valve endocarditis is 85% with a specificity of 81%. Given the much higher sensitivity of FDG because you're on a PET scan, then it is, in my opinion, the recommended first step to look for prostatic valve endocarditis. There is sometimes difficulty because of the physiological uptake in the prostatic valves. I would use a white blood cell SPECT CT as a second step in those cases that are equivocal on FDG. Or if you have, like Dr. Pryor, autologous labeled FDG white blood cells. So the added value of PET CT has been demonstrated in multiple studies in the prostatic valve setting to be very useful, to change management, to correctly reclassify patients. And it's been demonstrated in many studies that for the prostatic valves, the sensitivity is much higher than that of native valve endocarditis, which we'll be talking about soon. Not only are we able to detect the infection in the valve itself, but also at the same time, using the whole body scan, look for septic embolism, which are quite frequent. Also diagnose incidental malignancy, often GI polyps, which could be the source of the infective endocarditis, or if they don't have endocarditis, given that the FDG is the gold standard for fever of unknown origin, identify the alternative causes of the patient's bacteremia, fever, etc. So in the setting of prostatic valves, for several years now, since 2015, it's been integrated into the European guidelines and more recently in the 2020 American guidelines for the management of infective endocarditis. Patients with possible IE in the prostatic valve, it's now a major criteria if it's an abnormal FDG PET or labeled leukocyte SPECT CT. It's a major criteria for the diagnosis of infective endocarditis. So now in this flow chart, the recommended state-of-the-art management of prostatic valve infections includes doing the Duke's criteria, classifying them as rejected prostatic valve endocarditis, possible infective endocarditis, or definite IE. In the case of rejected endocarditis, then you still get a PET scan because you want to look for alternative diagnosis. In the case of possible IE, then you get a PET scan in order to see if there is or not the valve infection. And even when you have a definite endocarditis, then you still need to get a PET scan because you want to stage the disease and see where the septic emboli are. So in all cases, all these patients should be getting PET scans nowadays. So what's important to be aware of is that normal prostatic valves are associated with some mild homogeneous FDG activity just because they're prostatic material inside the body. So usually it's diffuse. It could be a bit more focal near the struts. In the mechanical valves, there's more uptake usually than in the biological valves. Surgical adhesives, Teflon, glue, all those can cause some more focal uptake that you have to be aware of. Always interpret these studies in conjunction with the surgical report. It helps you identify exactly what happened in the surgery, what they put, if it's not always described, but sometimes you'll see that they had redos, etc., and you'll see two layers of stitches. You'll need to be able to identify these to not misinterpret the findings as infection. Always important to always review the non-attenuated correction images in order to identify the AC artifacts, although much less frequent with digital and more recent PET scanners. So this is a slide demonstrating all 4 different valves and infections of them. You can see that in general, it's associated with focal, intense uptake in the valve. and in the case of tricuspid valve example, classically associated with lung emboli. So moving on to native valve endocarditis. Classically, and this is what I used to present, is that anytime you have focal uptake in a native valve with well-suppressed myocardium, that's always pathological. With our new digital PET scanner, we noticed recently that when you have severe native valve calcifications, there's always a bit of inflammation. And I think in Los Angeles, the Cedars-Sinai group has been publishing about that active calcifications in valves is associated with some mild FDG uptake. So that's one thing you have to be aware of, that sometimes densely calcified valves could be associated with some mild diffuse uptake. But in general, in a well-suppressed myocardium, any focal uptake in the valve plane is pathological, not like in the prosthetic valves where you can have some physiological variance of uptake. In the native valves, there should never be any abnormal uptake. So in the setting of native valve endocarditis, a PET scan would be indicated when there's possible IE by Duke's criteria, especially when the TE is equivocal or contraindicated, and in cases of definitive endocarditis to look for septic emboli. In the same meta-analysis, the sensitivity of PET scans for native valve endocarditis is much, much lower, 36% compared to the 80–90% range that we see in the prosthetic valves. However, the specificity is nearly perfect compared to the 80–85% range you're going to see in the prosthetic valve endocarditis. Why? Because these studies were done on older PET scanners. They were done with BGO crystals, or they're done with first, second generation LYSO crystals. It's been shown in a study that we performed together with the Montreal Heart Institute that using the latest generation analog camera, the sensitivity in our study for native endocarditis was 68% with a specificity of 100%, so which is much, much better. Now we're actually doing a multi-center prospective study looking at native valve endocarditis with a digital PET, and we're expecting to have results even better than the 68% values that we got on the best analog. So really, because the native valve endocarditis are usually associated with more smaller, more mobile vegetations, we have had difficulty in the past to identify them. But with better PET scanners and proper techniques, then we're able to identify even the native valve endocarditis. So here's some examples of the different valves. I don't have all the valves, but I could only get 3 valves because native valve endocarditis are rare to detect on every single one of the valves. I do have an example of an IV drug user with a tricuspid valve on the right. So you can see that there's very focal uptake in the valve planes, and that's abnormal. We don't expect that in a native valve, and these findings are consistent with endocarditis. So other than the detection of the infection itself, then the whole body PET that we do, which should be from the vertex until the upper thighs, and select indications to the feet when there are clinical symptoms, but definitely including the vertex, because even though we're not as good as MRI for cerebral emboli, we can still detect them and might as well just include it at the same time in order to assess the brain at the same time, although MRI is definitely better to look for cerebral emboli. It changes management in 10% of the patients. So we detect the GI polyps or the cancer in about 10% of the cases, which is often the source of the infective endocarditis. It's very common to have septic emboli, 20 to 50% of the cases. It's a prognostic factor, often silent. And it changes management. Patients who have a PET scan have 2 to 3 times less relapses than patients who don't have a PET scan, because you're able to identify the septic emboli, treat them locally, and therefore reduce the risk of relapses. And in 50% of the patients, then the PET scan is going to be the only imaging study to detect the septic emboli. So here's an extreme example of a patient coming with a native valve aortic valve infection. Patient had an FUO, wasn't suspecting a native valve endocarditis, but we diagnosed it. And look at the extent of the septic emboli to the brain, to the prevertebral soft tissues, to the lung, to the kidneys, and to the bone. So, you know, similar to oncology, when we stage patients to look for the staging of the whole body, we have to realize that infective endocarditis is a systemic disease as well. And we don't have only to treat the heart itself, but to treat the entire body in order to better take care of the patient and reduce the risk of complications and relapses. Here's some more examples of septic emboli in patients with infective endocarditis. Septic coronary arteritis, patient died soon later. Septic splenic infarcts, relatively common. Spondylolischitis, relatively common. These are routine cases that we can see quite often, except for the septic coronary arteritis, which is not that common. Moving on to cardiovascular implantable device infections, also associated with a low incidence of infection, but a high mortality, not always easily diagnosed. Lead infections can be sometimes diagnosed with ultrasound, but often difficult, whereas the FDG PET scan can detect not only the cardiac device or box infection, but even the lead infections. So in a meta-analysis of 11 studies, the sensitivity of PET with FDG was 87% with specificity of 94%. Very high mortality, also because maybe there are septic emboli that are not being treated. FDG PET therefore detects 30% of cases of septic emboli, which allows for more appropriate and guided therapy. So this has also been integrated in the latest algorithms from this year, where just like in the valve infections, with suspected CIED infection, then you need to get a PET scan as well, not only to look for the infection, but maybe also to look for the septic emboli. So here are some examples. This is the image on the left is a patient with a pacemaker box infection, whereas the patient on the right has not only a box infection, but we can see the uptake tracks along the lead, involving the lead as well. They have septic emboli as well. So in this patient with an extensive lead infection on the right that you can see with the arrow, it's a patient that's intubated in the ICU, but we can also see that there are lung and brain emboli. Now, so we can detect the infection when in these valve and cardiac device infections when they come, but the strength of FDG is also in identifying the alternative causes of fever. So this is an interesting case from last week. Patient came in with, he has a pacemaker. They were looking for a lead infection. Patient had fever, didn't know the cause. So we did a PET scan. There was no infection of the pacemaker. However, if you notice on the MIP images on the left, then the kidneys seem not to be functioning so well. There's a lot of stasis in the ureters. The bladder has a half moon crescent shape, not very typical of what we usually see. So we cut through the kidneys on the next two images. We see a bit of hydronephrosis, and there's some non-radioactive urine in the bladder. Why isn't the urine? Why is he stagnating urine? What's happening here? Cross-sectional images is the next image, and we can see that there's air in the urine and there's gas in the bladder wall, emphysematous cystitis. Why? Go a few slices down, we see that there's a large FDG-avid area of photopenia, not only in the bladder, but also on the prostate. You look at your CT images, and there's a balloon. The Foley was inflated in the prostate gland. So it was causing bilateral renal obstruction, hydronephrosis, emphysematous cystitis. This was the cause of the fever, not the lead infection from the pacemaker. It took a PET scan to diagnose that. So these patients often have bacteremia, and there's now evidence of survival and mortality benefits in patients who have FDG PET scans in the setting of bacteremia, because we identify the source of the infection, but also the extent of the infection, allowing better therapy. In one study of a prospective study of Staph aureus bacteremia, there was a lower mortality in the FDG group of 14% compared to 29% in patients who did not have a PET scan. So not only are PET scans I would argue cost effective, but they show mortality benefit and a significant change in management. So here are some examples of some cardiovascular manifestations, complications of bacteremia, infectious arteritis, dialysis catheter infection, PICC line infection, and incidental spondylolischitis. Moving on to vascular graft infections, another cardiovascular severe infection, also associated with high mortality, another emergent and urgent finding to diagnose. Many different imaging procedures can be used for that. FDG PET has very high sensitivity and specificity. Now, again, as this is a prosthetic material, there's some mild, usually homogeneous uptake in these vascular grafts, depending on the type of material that was used, and it persists forever. It doesn't necessarily go away with time. And the interpretation criteria, there's two different theories. Some use the focal heterogeneous uptake, the abnormal pattern of uptake, a non-physiological pattern of uptake as abnormal. And there has been one study that developed a 5-point grading system describing the differences in intensity and focality of uptake as negative or positive for infection. So if we look more closely, we can see the differences between what's physiological activity, which on the MIP image, where it says non-infective axillofemoral graft, we can see mild diffuse uptake throughout the graft. That's a physiological pattern of uptake, non-infection. Whereas he has also an iliac graft, which has very intense uptake with a fistulous tract going into the soft tissues. That's an infected pattern of uptake in the vascular grafts. Some more examples of intense and heterogeneous uptake in vascular graft infections. Of course, FDG PET is not without its limitations. There's areas that we're not very good at, such as the brain, the GU tract, sometimes the GI tract, sometimes the lymphoid tissue in the head and neck because of the variable activity. It's not infection specific. There's uptake in malignant cells and in foreign body inflammatory response. Early infections could be more difficult to diagnose, although there is more and more evidence that we could diagnose early postoperative infections. The scanner has to be available. Not everybody has a PET scanner, although hopefully more and more will. And there is a thought that it should be used exclusively for oncology, although I think infection affects not only oncology patients, but is a more urgent diagnosis, which the FDG PET scan can have an immediate impact on mortality. One thing to be aware is that abscesses, since they're mainly made out of necrotic tissue cells inside, the only uptake you're going to see of the FDG is going to be in the rim in the wall of the abscess, because that's where the viable cells are. So there's still some further information, research that needs to be done in terms of FDG PET, more data on how we can monitor response to therapy. When can we stop medications that are toxic or expensive earlier? There is some early evidence that, at least in the Staph aureus bacteremia setting, that may be useful. Can we show cost effectiveness? Can we show more studies to reduce relapse and morbidity rate? That's going to help to further approve the use of FDG PET for reimbursement. So there are sometimes missing some standardized reporting criteria that we need to develop. Can we have some more infection-specific radar tracers, especially when there are prosthetic materials such as prosthetic valves? That could definitely help. And we can always work on protocol improvements, better PET scans. Timing of the uptake using CT contrast can help at the same time. So in conclusion, FDG PET CT has an important role in the diagnosis of cardiovascular and device infection, and it has a significant amount of advantages over radio tracers, and I would argue that is cost effective and cheaper than using other radio tracers. We need to have rapid and flexible scheduling. We need to respond very quickly, image the patients very quickly. We can't wait a few days or weeks to give them appointments. We have to respond to the demand and schedule them when they're clinically necessary. Once you inject the patients, you get the results within 2 hours. You can have the report out rapidly. Changes in management could happen quickly. You don't need to spend 2 days, 1 day in hospital, taking a bed, waiting for a diagnostic test. Whole body, we do a whole body test. We can guide biopsy management, treatment, stage the entire infectious disease picture. And if we can get some infection-specific radio tracers that are available, that are cheap, and that are easy to use, then in certain specific settings, it should definitely have an important role to play.
Well, first of all, I'd like to thank all the speakers for being on time. It's well appreciated, and that gives us more time to chat during our discussion session. I would like, if you do have questions, I would advise you to come up to the mics because all the audience wants to hear what question you're asking. And if you ask from your chair, we may not understand that, so that would be appreciated. And so if you start thinking of some questions, I have a few questions actually for all three people here, so I can start off as the other members of the audience get up to the mics. Dr. Pryor, I was quite interested in the time of flight type of approach and the challenge you were putting out there. And one of the statements in your slide, you're talking about the psychiatric application for time of flight approach. Are you able to expand on what you're hoping to do with that from a psychiatric perspective?
Well, it's a very good question. It's just in relation to the radiation dose you could get from such examination. So far, there are no real specific application in the clinics of psychiatric imaging, but we do hope that coming up with more specific, for instance, schizophrenic tracers that could be showing up neuroinflammation at specific time in age. It's something that could be developed, but of course, you cannot do it if you do a lot of radiation. So that would be requiring the imaging of younger population, adolescents and younger adults with specific tracers, but of course you would like to get the lowest amount of radiation. So those are studies to be done, but this technology would allow such study to be done.
Okay, that's great. Thank you. That's there's a lot of interest in certain aspects of nuclear medicine with the psychiatric applications for what we can offer. So this is quite exciting if it does move forward. Dr. I stutter a lot, so you're going to have to forgive me. You were talking about infective specific type of tracers for PET. Is there anything in the pipeline that's going on now for research development on that
There
point?
are many that are undergoing research. Several have not panned out. Several are not broad enough. In practice right now, I don't think there's much that can be used. Maybe autologous white blood cells, if you're able to label them, is a good approach. Gallium-68 has also been used with limited success. And there's some now bacteria-specific imaging agents that are being developed as well. But these are going to be pathogen specific, so they're going to be limited in applications. And again, it's hard. It's going to be hard to compete with the cost and availability of FDG once they are available. So it's probably going to be a question of specific indications for these tracers.
Okay. You mentioned the difficulty in getting your inpatients monitored. I thought it would have been the other way around because they're in the hospital and you can only eat what they get in the hospital. So what's the issue with that?
Well, yeah, I think unfortunately it's the lack of, when they tend to be in a hospital, patients tend to not be informed of everything they need to be informed of. And so they're not always aware that what they're allowed to eat, what they're not allowed to eat. They're just given the diets from the they prescribe a cardiac PET diet in the notes, and then the dietetic service is going to provide it. But does the patient always know that they don't need to, they can't get food from outside? Family members come in and they bring them food. They're going to eat it. Do they know what they're allowed to, what they're not allowed to do? So there's communication approach that needs to be improved. Then there's also nursing coordination that needs to be improved, because every time they're injecting medications, they're often injecting dextrose with it. Sometimes they're on dextrose strips. Sometimes the fasting is not always observed. So it's a whole, it's a challenge, and it takes some time to set it up properly. But once everybody is aware of it, and once everything is set up properly, then the success rates of myocardial suppression, even for inpatients, improves a lot.
Yeah, I can relate to the concept of diet, etc., because we have what's called a rapid assessment cardiac program in our hospital there, where we're trying to do the MIBs within 24 hours of admission for those individuals. And again, they all come down with coffee, even though they're told not to. So it does an issue. Dr. Packard, You mentioned some cases.
Sure.
Yeah, that'd be interesting. We have some time, and so far I see no one at the mic, so let's move forward.
Get my slides again, please. Thank you.
Yes, absolutely.
Hear me, I guess, while we're waiting. So for Dr. Pryor, what do you think the value of non-attenuation corrected PET, cardiac PET images are? Do you see any? Because in SPECT, when we do attenuation correction, we usually look at the non-attenuation corrected as well, but it's not very common right now to look at the cardiac PETs.
It's a good question. We do have attenuation correction that we have set up. We do very low radiation burden images, and that allows us to be a little bit more quantitative. So the radiation dose just from this CT scan is low, and we have seen that we can also get the calcium scoring, and we do see now and then lesions in the lungs. So I would tend not to bypass attenuation correction, but I do know that if you do O15 water, you don't need any attenuation correction. But for regular rubidium, I would still do it.
Sure, I paraphrase. We do attenuation correction, but is there any value to review the non-attenuation corrected images?
Sorry if
Sure.
I misunderstood your question. That would be the case if, for instance, you see weird patterns that could have been induced by, for instance, prosthetic valves, or now and then we have left ventricular assisting devices that are also in place, and it's always good to review the non-attenuation corrected images.
Thank you, I appreciate it.
Are you all set?
Yep,
Okay.
all set. So I have
And then after that.
2 examples for you guys. So again, this is looking at segmental versus territory flow metrics. So this is a case of a 65-year-old gentleman who was enrolled in the trial, and his on the left you have the perfusion quant images, and his automated relative perfusion quant did not detect significant CAD with a deficit at stress of 2% globally, which was inferior to our validated threshold that I mentioned briefly of 8% for CAD, 50% stenosis detection. And so basically he had no, based on the relative perfusion, no significant disease in any of the coronary distributions. So the territory value, which is the middle figure, the territory stress flow was significant for a value of 1.3 in the LAD territory, indicative of LAD disease. And when you look now at the segmental values, and it may be a little bit small to see, but I'll give you the numbers. The segmental stress flow was significant for values of 1.3 in the apical anterior segment in the apex, indicative of LAD disease, and the value of 1.3 in the apical inferior segment, indicative of RCA disease. So I'm giving you his invasive coronary angiogram results, which demonstrated a 64% LAD lesion, no disease in the circumflex territory, and a 56% disease in the RCA. So while the relative perfusion quantitation was falsely normal, the territory stress flow only detected the LAD disease. The segmental stress flow correctly identified, in this case, 2-vessel CAD. So this is an example of an abnormal case, also to show that even in these you'll have, you may have an additive contribution of flow metrics. So this is an example of a 52-year-old male who was enrolled in the trial, and the automated relative perfusion quantitation demonstrated a deficit stress of 34% globally, 1% in the LAD distribution, 93% in the circumflex territory, and 66% in the RCA territories, consistent with significant CAD in the circ and RCA territories. The territory stress flow, which is again the middle panel, was significant for a value of 1.1 in the left circumflex territory and 0.9 in the RCA territory. And now when you look at the segmental values, and again, I'll share them, the segmental stress flow was significant for values of 1.0 in the apex, indicative of LAD disease. It was basically diffusely decreased in all the lateral segments with the lowest of 0.7 in the mid-inferior lateral segment, indicative of left circumflex disease. and also diffusely decreased values in the inferior segments with the lowest of 0.6 in the mid-inferior segment, indicative of RCA disease. And you have here his angiogram results, which demonstrated 59% LAD, 66% circumflex, and total occlusion of the right. So that's why I'll write relative perfusion quantitation and territory stress flow both identify 2-vessel CAD. Segmental stress flow correctly identified 3-vessel CAD. You could be like, does it really matter, once the patient has got 2-vessel CAD that you detect on the perfusion scan, they're going to go to the cath lab anyway. I would argue it's actually very important because the interventionalists would like to know before they engage with their catheters inside the coronary territories if there's like a diffuse disease or not, because sometimes they like to do a non-selective engagement of the coronaries to prevent any ischemia and ventricular tachycardia on the cath lab, which no one likes to have. So these are the 2 cases.
Okay. Thank you very much. Dr. Pryor, you had a question.
Yeah, I had a question about infection for our last speaker. How do you see the value of dual time imaging, and do you do it in practice?
I don't think it could differentiate between malignancy or infection because there's not enough data that could be used to differentiate. And I think both processes are going to have a lot of uptake over time that may not necessarily diminish or change over reliably to differentiate between infection or malignancy. Where we do use it is delayed images is in order to improve our target to background, especially when we're looking for small foci of uptake in native valves. Then we routinely use delayed images because we start with the whole body acquisition, which we can start at around 60 minutes with our digital PET scanner, and we're finished 10 to 15 minutes later. But by 75 minutes, the blood pool has further cleared compared to the time that we started our 60-minute images. And we're then able to then do a focused and dedicated image of the heart at 75, 80 minutes. Together with 5-minute acquisition instead of a rapid 2-minute bed. So when we're looking for small foci like in the native valves, the delayed acquisitions definitely improves our target to background and sensitivity, or clarifies equivocal foci that we're going to see on the initial images. So for native valves, we routinely do 2 dual time point or delayed images.
And for that image, to use gated acquisition?
We do.
And for that late image, to use gated acquisition?
We do gated. I can't.
Okay.
Is on or not here. It can be a challenge with infection imaging in diabetics, in terms of preparation, holding insulin, holding diet. The infection itself can create hyperglycemia in diabetic patients. So I'm just wondering, do you think white cells imaging may be preferential in diabetic patients over FDG PET?
In which clinical context?
Well, for cardiac infection.
Okay. First of all, with FDG in the setting of infection, there are a few papers that have been published. One from when I was in fellowship that shows that hyperglycemia does not, and even in diabetic patients, does not affect the results of the FDG PET scan for infection imaging as much as it does in malignancy. So and there's a few other papers that have demonstrated that. So in practice, even in the setting of hyperglycemia, in diabetic patients, which is a common problem because their glucose control is affected by infection, we still do the FDG PET scan no matter what their glucose level is in general, especially if they haven't received very insulin recently on board in the last 4 hours. But even if they have a glucose of 13, 14, then for even 15, then we still proceed with the study. And in most cases, we haven't had a problem. I don't know if the uptake is maybe slightly reduced compared to what would have been otherwise obtained, but the images in order to diagnose the infection has never really posed a problem. And we routinely do it because in our center now, we don't use any other infection radio tracers. We only use FDG generally, even for diabetic feet, for any infection indication. In selected cases, we'll then proceed to other tests. But we'll always first start off with an FDG just because it's cheaper, more practical, and more rapid to get. So so we even diabetic feet, and then where they have where we don't have any, where they have often significant high glucose levels, it hasn't affected so much our practice or canceled scans because of that, or the quality of or the results that we obtained in order to diagnose the infection.
Great, thank you very much.
Okay. Yes.
I just wanted to second that we do the same thing for infection and in our diabetic. The major problem is the dextrose they give them, because even they put the NPO, the nursing doesn't repair. So when we get a request, we make sure we emphasize for house staff or doctors to put specifically no dextrose. That messes up the images more. And then one comment for all of us, we're getting new PET CT scanners. I've been involved in different with the hospital management, and they always think that our imaging is usually can be done as an outpatient. So, but if you're thinking about more acute applications like infection, it has to be considered that PET scanners is much more convenient if they're in the hospital, because to cut costs, they've moved the nuclear medicine outside and say, oh, we carry for few VQ scans, we just bring the patient there. But if the patient is ICU and need infectious imaging, then it's convenient. And it happened to one of my relatives that had endocarditis, and I said, why don't you get PET? And said, oh, this PET, the hospital PET center is outpatient, so we can't really take the patient there to get the imaging done. So it's very important when there are meetings, show up there and represent nuclear medicine, especially for our younger colleagues, to discuss the importance of more acute imaging, because the general opinion is nuclear medicine is not really acute imaging, so it's new applications. And the second thing about your cardiac same day, we use the flow imaging as a method. We had patients coming in that had caffeine and showed up with chest pain, and we were discussing if we can do rubidium imaging same day, and I told them, we can do, and if we see increased flow, that basically tells that caffeine effect was not there. So we expedited some patients, they got the catheterization next day instead of waiting 24 hours and do the imaging. And if the flow is not increased, then we see maybe due to caffeine effect. So that kind of another way. It's a non-clinical use, but can be helpful in clinical applications.
Okay, great. And as the adage goes, it's always important to be at the table when we're dealing with nuclear medicine. Sir, you please.
I have a question for Dr. Packard. When doing myocardial blood flow quantitation, there's a subset of patients who will display abnormally, higher than usual rest flow. And it's been proposed, but I don't think formally demonstrated. This is sometimes related to hypertensive cardiopathy. Actually, my question is, do you take that into account when importing the reserve flow, which basically will be affected by this, and especially in cases where the semi-quantitative images won't show any regional ischemia?
Yeah, that's a very, very good question, very pertinent, because one thing is that, we report flow in kind of research centers, etc., but in terms of widespread adoption, it hasn't fully taken off. And one of the reasons is what you're alluding to, which is a lack of standardization. So there are definitely instances in which rest flow is elevated, and some people have proposed correcting for the rate pressure product of heart rate and systolic blood pressure. And what exactly that correction value would be is also a little bit arbitrary. So an exact correction is out there in terms of potentially being done, but it's not systematically done. What I can tell you is two things. The first one is that in the trial, rate pressure product was not corrected for. That's one thing. The second thing is that may be why, stress flow ended up being a better indicator of significant CAD compared to myocardial flow reserve. That is a possibility. I would cite a paper by Johanni Knuti in Finland, where they looked at actually systematically in a group of patients with oxygen 15 water. They looked with and without correction for rate pressure product in patients also who had abnormally elevated breast flows, and they didn't see a significant difference with invasive coronary angiography as a reference standard. So there's not a good standardization in the field, and your question is, I think, very pertinent. I think one way or another, if you look only at stress flow, you would, however, circumvent that problem. And to continue on that, I would say that more and more the way these flow metrics are being proposed to be used clinically is if your goal is to determine whether or not your patient should go to the cath lab, and usually that's the question we're being asked, stress flow is probably the better marker. If your goal is to understand long-term over the next 3, 4, 5 or more years how well your patient will do, probably myocardial flow reserve is the better marker there. And I think probably in part due to the reason that Dr. Pryor mentioned, which is an integrated assessment of your epicardial disease and your microvascular disease, which is obviously very important prognostically. Thank you.
Okay. Well, great. Those are good conversations. Thank you. I see no more questions coming to the floor.